Next, we have Dr. Darrell Gray, who is the inaugural Chief Health Equity Officer for Anthem, who just started a few months back in August. Prior to Anthem, he was an associate professor of medicine at The Ohio State University, was a practicing gastroenterologist there with Ohio State, as well as deputy director of the Center for Cancer Health Equity at Ohio State's Comprehensive Cancer Center. So welcome, Dr. Gray.
Thanks so much, Freddie, for having me. Really excited to be here and join this illustrious panel of speakers.
So I guess one of my first questions to you is, there's been a lot of attempts to try and address these issues in the past by different parts of the healthcare system, inside and outside. But what do you think have been those biggest roadblocks or challenges for innovating new solutions, whether is it at the ideation level, creation level, is that the implementation level, scaling level, or is it sustainability issues?
Thanks for that question. I think, Freddie, honestly, I think the issue and the problem, the barrier has largely stemmed from us, in that we try to center our own ideas and then take those ideas into the communities that need it most, without actually centering at the margins, meaning amplifying the voices and the ideas of the community. And I can name instance after instance where that has failed us. And so it's really up to us to really center at the margins and really amplify the voices of our community, but also share power and resources with those within our community, because that's where those who are most proximal to the problem, those who are most proximal to the inequity, are most likely to have the solutions. And I think we have to do a better job. And the truth of the matter is, and I think some of our prior speakers alluded to this as well, is that we, whether it be researchers, whether it be physicians, we honestly haven't been great trusted brokers in the past. And so it's no surprise that as we're trying to develop solutions, whether it's amidst the COVID-19 pandemic or otherwise, that we aren't trusted and people don't just jump at the bit to accept what we want to give them. And so I think it's really up to us. And I really applaud our prior speakers for really highlighting this, that we must engage our communities. Community engagement is much different than community outreach. Gone are the days when we should pat ourselves on the back for doing health fairs where we check blood pressures and do finger sticks for blood glucose. No, community engagement means that we really work with our community in co-design. So if we are co-designing with our community, we are more likely to be able to aptly address some of the inequities that we see in our community.
I think, as you said, many of our speakers have brought the whole point of ensuring that we have the people to which we're developing solutions for at the table from the very beginning, right? At the problem definition and the solution development. But oftentimes these populations are also the hardest to reach. And it's not simple. I mean, distress is certainly part of it. But what are some ways that, especially if we think about the participants during this hackathon, one of the things we always tell them is, go out there, go talk to people, talk to people in terms of testing and validating your thought process, your hypotheses, your ideas. But how do you reach those individuals?
It takes me back, early in my medical career when I was actively practicing, actually in training, someone said a quote that has really stuck with me. And that's, people don't care how much you know until they know how much you care. And so really, if we're going to reach different populations, that it's not necessarily that they're hard to reach, but perhaps we haven't been trusted enough, and rightfully so. We haven't earned that trust for us to stay connected with them. I think, part of it is we have to take off our white coats those of us who are clinicians. Those of us who are in the lab, whether a dry lab or wet lab, we have to step outside of our laboratory and spend time in the community. And one of the things that when we do engagement, it's not for always the intent of what our study is or what our project is. If we do just that, it's kind of like helicopter research, meaning we fly in to do our study, to do our survey, and never to be seen again in the community. That's not what the community wants, and that's not what they need. They need someone to be there, to understand them, to know them, to work with them. And so I think if we are really going to be genuine and authentic in this, we have to be in the community for whatever they want. So that may be in conflict or a competing interest or priority to what we have for our research agenda. But that's part of relationship. You may have to attend a meeting, a town hall that has nothing to do with what your research agenda is, but that's how a relationship is built. And so it takes time. And a lot of times we think about, well, we don't necessarily always have the time, but it does take time to build relationship. And it's through relationship that we can make change. And the other point is, a lot of times when we go to the community, we don't go to the community speaking a language that they readily understand or speak. And so a lot of times we have to throw our jargon aside and come to conversations authentic in a way that they can understand. And part of that, maybe it's not us being the speaker, but maybe we also use trusted brokers, community-based organizations, churches being another example where people are trust the authority figures in that setting, and maybe they can be the person to speak on our behalf. But I think we have to leverage relationships in a way that we have not in the past, because what's been talked about today as far as mistrust is very real.
You bring up a couple of points. One is, really trying to figure out who are those individuals that are the trusted brokers that people more feel either trust, more comfortable with, associated with. I mean, we see that, of course, even for looking at one of the challenges for this hackathon and diversification of our clinical workforce, right? We're trying to find ways to better, represent who our patients are so that they can better connect and get better care. I guess to that point too is, one topic that hasn't really been hit on tonight yet has been around the issue of intersectionality, right? How do we start thinking about health equity and, there's at the population level, public health level, but then now at the individual level or subpopulation levels where, at what point are we treating an individual versus, a population?
Yeah, I so appreciate that. And I'll put it in perspective of who I am and why I think it's even important beyond the individual level. So what others may not have gotten in the introduction, the nice introduction you gave, Freddie, is that I'm a believer. I am a husband of 11 years. I'm a father to 3 kids, 3 little kids and a 4th on the way in February. I am a physician, a community advocate, a researcher, and all of those things inform who I am, but also my perspective, right? So those things have afforded me to have social networks, so that social isolation, for example, is not a huge issue for me. It's allowed me to be able to live in a neighborhood where my kids have access to green space and safe sidewalks. It's allowed me to live in a place where I don't have to worry about dilapidated, housing, for example, that my neighbors may be exposed to or have the health consequences of as a result of living in that. And so I recognize that I bring privilege because of these experiences that I've had, but I also recognize that there are many, even within arm's reach of my family, that do not have the same privilege or come up from very different lived experiences. I also understand that even though I'm a Black male, I can't necessarily just go into every Black audience, for example, and feel as though just because I'm Black that I will automatically be accepted. No, that's not the case. And that's a misconception, because I think, part of it is people may say, well, you're Dr. Gray, you come with a doctorate, right? And so you don't necessarily see through the same lens that we see through. And so that's again why number one, we have to understand each other and each other's experiences, but we can't make presumptions, just like going into the community and presuming that because you're from the community that you'll be accepted by that community for whatever your agenda is. So as we think about intersectionality, and particularly for those innovators out there, I think we have to do a better job of understanding and capturing what that intersectionality is. Prior speakers have talked about social determinants of health. Others may be familiar with language like health-related social needs. That's a gap. Capturing actually, as we think about patients, so we think about just people in our communities, being able to understand how we can better capture that information so that we can tailor data-driven, community-engaged solutions for these populations that are most vulnerable and most need our assistance in kind of closing these inequities that we're seeing in our environment. But I think you bring up an outstanding point that we need to do a better job of understanding intersectionality. I'll tell you, from the bench, lab bench to the bedside, and certainly in the community.
In your opinion, I mean, there's in the health equity space, obviously, there's no shortage of problems at hand. Do you think there are, in terms of inspiring our participants, should they be reaching out for sort of the really high, goals and problems, or do you think there are low-hanging fruits that can easily make a meaningful impact that they should be tackling?
I would say, Freddie, it's not an either or, but it's a both and. I think we start, where you are, and maybe even it might not be trying to develop a small solution. It may just be working on yourself. And I'm not saying that lightly. I mean, it's understanding and identifying what our own biases are that are preventing us from having a significant impact or perpetuating inequities. And I think that's part of education. So it could be starting with education, not only of ourselves, but our peers and our coworkers and frankly, some of our family members, right? But I do think there are large problems that need to be tackled. I think food insecurity needs to be tackled. Homelessness needs to be tackled. Income inequality needs to be tackled. And frankly, even one of the most preeminent social determinants of health, racism, needs to be tackled. And I think that there are many people who are outstandingly brilliant in this hackathon who can help to contribute to making solutions to eliminate those things. And certainly we see digital solutions that are trying to do just that. I was on a call with someone from Bento recently, and their kind of food insecurity solution. So there are many people who are thinking about these huge problems, but also they're trying to think about at the individual level. And I think that's what we have to do. What can we do as an individual within our own networks to tackle these big problems?
One of the things that came up during the health conference that the panel you were on really spoke to was, how do you think about building equity into every process or everything that you do, right? It's, we touch a little bit on that throughout this evening in terms of thinking about, how do we ensure technology doesn't further widen the gap in inequities, right? For the activities that we do, or even the process that we are doing this hackathon or this problem solving. Can you speak a little bit more to that?
Yeah. Yeah, I think, and certainly since I started my role at Anthem, what I see my job is ensuring that health equity is everyone's business. It's not the business of one chief health equity officer, Darrell Gray, but it's everybody seeing what their role is within the organization, no matter what they do. And so part of that is equity by design. It's certainly for those of us who are in different, whether you're in academia, whether you're in the private sector, whatever you do, you're tuned into this hackathon, know that you have a role to play, and it's everyone's business. We have to make sure that it's equity by design in all that we do. So maybe it's on your team asking the tough questions of, maybe you're developing a startup, or maybe you are going to contract with a startup, and it's asking the tough questions of, who will this technology touch and who will this technology not touch? How do we get community buy-in into this tech solution? What are the potential downstream poor outcomes that may come as a result of this? Are there opportunities to exacerbate disparities with this technology that I'm developing? Am I introducing bias into this system? And certainly, I think someone highlighted this earlier, but certainly there's bias in AI, artificial intelligence, and because we bring our own biases into things that we develop. And so we have to start asking the really tough questions at the micro level, so that once we get to the macro level, when the solution is developed, we don't look back and say, oh, this did exacerbate. No, we have to put equity in design of everything we do, from development to research, to then dissemination of that knowledge. And so that's part of what I've been trying to do and continue to do with our team at Anthem, is ensure that as we're going on this journey, we have a mission to improve the health of humanity. We have to do it through an equity lens, whether it's our digital and tech teams, whether it's our commercial product developers, whether it's us in community health, in our health outcomes organization. We have to make sure it's everybody's business and everybody's job, but that also we are one band, one sound. This is bringing up my Ohio State days, one band, one sound, and advancing toward that goal.
Thank you so much, Dr. Gray, for your insights. I think it's a perfect way to and at least our series of speakers.